Let's continue from septic arthritis, then talk about myositis, and then I think that concludes the majority of our theoretical part. نضل علينا session that we do for questions and answers. Session راح نحكي فيها clinical vignettes. تمام. So what is septic arthritis? It is the inflammatory reaction of the joint space. راح تشوفوا قصة اليوم. It's very closely related to many conditions that we mentioned so far, but this is an inflammation in the joint space. So this is caused by an infectious agent. It's usually caused by bacteria, but may be caused by mycobacteria or fungi, and it's very common and hard to treat due to the use of prosthetic joints. Almost about بحكي لك من 2 إلى 10% of all prosthetic joints will have septic arthritis, and obviously we know at this point we know why. Also common among immune compromised and elderly. The aging population, and then people with immune compromise will have septic arthritis. So 45% of people with septic arthritis are above 65, and more than half are male. The etiology, so this would be our table slide. What do we have here? It is quite very similar to the slide from the previous lecture on osteomyelitis. It's very quite similar. So you can see that here the most common would be staph, again for the same reasons, and then coagulase negative staph, again also for the same reasons, biofilm formation. Streptococci, group A, B, C, and G, and then strep pneumonia and viridans group, about 20% of all cases. So this is something new here. So we have pneumococcus and viridans group are something that you do not usually typically see in osteomyelitis, are more represented in this case. Coagulase negative staph, the same thing. E. coli, the same reasons that we mentioned. H. influenza, تمام. بس Neisseria gonorrhea is the most common cause in sexually active young adults. So it's a very typical case. واحد أو وحدة بالعشرينات, a new sexual partner, a new relationship, and then later on بيجي مثلا with a swollen knee joint. Very common presentation. And then the other, هي شفنا قاعدين بنشوف إنها بالjoint space. شو قاعدين بنشوف؟ قاعدين بنشوف representatives of meningitis causing bacteria, strep pneumonia, Neisseria meningitis, and H. influenza. All of them cause septic arthritis. حدا بيسأل why صراحة, يعني this is debated. Why يعني بدك تحط انت هون خيارات that you have all these are capsulated organisms. هاي نقطة ثانية إنه you have more likely the ability to have a capsule. These organisms will survive the trip in the blood. نفس القصة اللي بالmeningitis. Why do they go to the joint space? It's anybody's guess really. It's still a debated subject. Pseudomonas, sternoclavicular joints, sacroiliac joints, Salmonella species, and other causes, Brucella polymicrobial. So the story is quite similar to that of osteomyelitis. So prosthetic joint infection. So according to the presentation, an acute presentation within 3 months will more likely to be Staph aureus. Subacute is after the 3-month mark, but before 2 years, and a chronic form would be more than 2 years. Overall, Staph aureus, but coagulase negative staph and gram negative aerobes cause delayed cases more. So the Staph aureus is more on the acute phase. Cons, the biofilm formers, and the ones caused by hospital infections are more likely to be in a delayed form. Epidemiology. The reported incidence of septic arthritis varies from 2 to 5 cases per 100,000, or about 8 to 27% of adults presenting with painful joints. So, يعني 27% of people with painful joints, it's septic arthritis is quite high. يعني others maybe it's usually يعني بديش تسمو تاخذوها من منطق so like it's not a single disorder. So these people have maybe septic rheumatoid arthritis, prosthetic joints, recent surgery, skin infections, ulcers, diabetes. They're very old. Intra-articular corticosteroid infection or injection, injection مش infection. Injection drug use, alcoholism, حتى osteoarthritis ممكن يعني destruction of joints will make them more susceptible for hematogenous spread. So فلما تحكي septic arthritis it could be part of other syndromes in an adult that presents with painful joints. هاي النقطة اللي حابين نوصلها بهاي السلايد، إنه it's not يعني a sole cause in about 8-27% of adults. Pathogenesis. Septic arthritis usually occurs after hematogenous seeding of pathogenic bacteria. This is the most common route. Like osteomyelitis, contiguous spread or direct auniculation can be also caused. Healthy synovial cells have phagocytic activity, and normally you'll be able to clear any seeding from outside sources. So any weakness in the immune system, as we mentioned, SLE, rheumatoid, increased age, whatever, can increase this likelihood. Previously damaged joints are more susceptible, like we just mentioned. These joints show new vascularization, new vessel formation, and adhesion factors, which promote bacteremia and consequent infection. Staph aureus, especially, binds to articular sialoprotein, which collagen, elastic, and prosthetic material via tissue adhesion factors that they possess. Infection typically damages the cartilage, so chondrocytes here are the target. So proteases of Staph aureus, the inflammation in turn causes further damage to the cartilage. Gonococcal arthritis exhibits much less influx of white blood cells in the joint, which explains why it is not as destructive to the joint as other bacteria. So an adult اللي إجا مع gonococcal arthritis is more likely to have near normal healing, يعني healing back to near normal levels, because there is much less destruction to the joint than others because of the less influx of white blood cells. Clinical features. So children and adults with acute septic arthritis usually present with fever and monoarticular involvement. This is very important. ما راح تلاقي septic arthritis يعني very hard to see it as مثلا bilateral knee joints. إذا راح يكون more than one joint affected, it'll likely be two non-related joints. يعني مش two knee joints, ممكن knee و ankle مثلا, or knee و hip مثلا, or whatever. But bilateral is very unlikely إلا إذا كان مثلا بالصدفة فقط لا غير. So the knee is the most common affected joint, followed by the hip. And clinical features include شو راح يكون, as you obviously can guess, swelling, pain, redness, whatever, and then you have reduced mobility in the joint due to the swelling. Polyarticular infection occurs in about 10 to 20% of patients, and those with especially those that have rheumatoid arthritis or viral causes. Infections with mycobacteria or fungi usually have an insidious onset. As you know, these are slow growers. Lab investigations frequently show a raised white cell count and then inflammatory markers. Joint aspiration will show purulent synovial fluid with an elevated white cell count, so 50 to 100,000 cells per millimeter cube, mostly neutrophils. This is very important, especially for bacterial causes. So it's good here that you review the numbers that you see in joint aspiration. White blood cell count in these setting. بالطبيعي ما لازم يكون فيه خلايا white blood cells إلا الخلايا that are migrating normally. فما راح تشوف أكثر من 200 خلية. هلا if there is chronic and insidious destruction زي ما بتشوفوا مثلا بالاوستيوارثرايتس, this level will start to increase. ليش؟ لأنك بدك white cells to absorb the destruction, but the destruction is over a very long period of time. فما راح يكونوا من أكثر من 200 لتقريبا 2000. And then في عندك حالات مثلا مثل الجاوت and then rheumatoid arthritis. Now هدول الحالات much quicker than osteoarthritis. هاي صار في inflammation, صار في something that مثلا في these crystals, الجاوت crystals are now in the joint space, أو مثلا صار في attacking the joint space by cells. So now there's a lot more cells going in. هدول الحالات مثلا you will see between 2000 to 50,000 50,000. هلا الحالات اللي فيها عدد هائل فوق ال 50,000 لل 100,000, هدول هون الانفكشن راح يكون infection. طبعا هذا راح يكون the quickest form of destruction اللي هو foreign invader اللي هو عندنا البكتيريا. Gram stain is positive for less than 50%, and culture is positive لتقريبا 90%. So if you take the synovial fluid and culture it, a very high likelihood to recover the causing organism. So synovial fluids in blood cultures bottles may improve yields as well. Sample should be sent for microscopy for crystals. Blood cultures حكينا are positive in majority of cases. Imaging radiographs of the affected joint may be normal at presentation. Typical changes are periarticular soft tissue swelling. Obviously لأنه في عنا inflammation سوف راح يصير في عنا swelling. Fat, pad edema, periarticular osteoporosis, loss of joint space, periosteal reactions, erosions, and loss of subchondral bone. Ultrasound can be used to confirm an effusion and guide aspiration. CT and MRI are highly sensitive for imaging early septic arthritis. CT is better for imaging bone lesions. Any bone lesion, CT is better. MRI may not distinguish septic arthritis from inflammatory arthropathies. So هون نطلع أول ما نطلع عليها بدي تفكر شو هو يعني the most striking feature here. So this is a 43-year-old female with a history of lupus treated with steroids, presents with developing left knee pain. So if this is the right side, هيحط لك R. And so this is no, I think this is sorry, this is hold on. So you would want to look at the most striking feature. So this is the right, this is the left, this is anterior posterior view, and the patient is upright. So طلع بين التنتين, the joint space here is very narrow. طلع soft tissue, the shadow. This is definitely much larger than the right side. So this is left knee pain, swelling. عندها fevers, عندها pain, but obviously swelling. So these are the most striking features in this case. Okay, so management, what do you want to do? You want to drain the joint. So either by closed aspiration or arthroscopic washout should be performed urgently. And then open drainage may be required either when repeated drainage has failed, or to control the infection, or for a drainage of hip joints. Prosthetic joint infection often require removal of prosthesis, as we mentioned before. What do we do for antimicrobial therapy? Well, according to the initial gram stain findings, empirically بتستخدم IV piperacillin, tazobactam مع أو بدون vancomycin. So you're covering all your يعني a lot of your bases here. Definitive therapy is tailored للsensitivity result. And then adjunctive therapy with a short course of systemic corticosteroid treatment has been shown to be of benefit in children with hematogenous bacterial arthritis. Now I'm going to start with myositis lecture. So myositis and myonecrosis. أول شيء بدنا نحكي شغلة مهمة. Polymyositis is an inflammatory condition. Pyomyositis is pus. Pyo مثلا here it indicates pus, and that's the muscle invasion of bacteria. So this is very important to polymyositis يعني إذا بتاخدوها بالنيورو is a progressive symmetrical proximal muscle weakness. So and then they have inflammation. This is a CD8 8 plus with T cells يعني لوقتها بتاخدوها. Dermatomyositis is something similar to polymyositis. But here our focus is on myositis or pyomyositis. Pyomyositis is Staph aureus, and then necrotizing fasciitis نفسها بس في اسمها هون necrotizing myositis, again group A staph عفوا strep, gas gangrene Clostridium species, again a very similar presentation. Non-clostridial myositis mixed here polymicrobial, and then there's a synergistic non-clostridial anaerobic myonecrosis, also with another different mixture of microbes. So muscle involvement in inflammation or infection. بشكل عام muscle involvement حكينا we have muscle pain that we feel during viral infections, part of the constitutional symptoms, and that happens in inflammation or infection. حدا تعبان بحس عضلاته تعبانة بتوجعه. So this is just a viral infection, myalgia, which is called muscle pain. Parasitic infection, you can have trichinella or cysticercosis, مثلا toxoplasma, can invade muscle. Then there is myalgia, muscle pain, which can occur in most of these infections. Severe muscle pain is the hallmark of pleurodenia, which is Coxsackie virus, trichinellosis, and then bacterial infection. Acute rhabdomyolysis is a breakdown of damaged muscle. Predictably occurs in clostridial and streptococcal myositis. This is very important because the release, if the destruction is released, this will be very similar to tumor necrosis syndrome. So when you kill a tumor مثلا quickly, you have a large influx of breakdown products من خلايا which can overwhelm the system, especially the kidneys. So acute rhabdomyolysis here might happen. This is might be a similar presentation. Rhabdomyolysis is less so associated with influenza virus, ecovirus, Coxsackie, Epstein-Barr, and then Legionella infections. Necrotizing myositis, group A strep, maybe here is the main agent, and can induce primary myositis, so streptococcal necrotizing myositis, and associated with severe systemic toxicity. So same as type 2 necrotizing fasciitis, that was not the monomicrobial one. So this one is just spread further down, and now is involving the muscle tissue. Necrosis here can occur in about 50% of cases in typical fasciitis without muscle involvement, being the primary tissue infected. So شو يعني إنه muscles that are affected by necrosis when the surrounding fascia is involved, even without the infection being active in the muscle itself. So you will have necrosis in the muscle even in the without involvement in the actual muscle by bacteria. So compromise of the surrounding blood vessels. هلا pyomyositis or pus forming infection in the muscle, مين هي راح تكون? Who likes to nest and make pus? Staph aureus. So remember, pyomyositis is common in tropical areas and generally has no known portal of entry. This is يعني puzzling. Again, القصة هنا بتزيد caused by MRSA with PVL toxin is now being described and increasing among children in the US. Muscle infection begins at the exact site of blunt trauma or muscle strain. شو يعني؟ محل ما صار في trauma and then or مثلا a very hard strain صار في breakdown. عادة إذا تلعب رياضة كتير very strenuous you will break down some of your cells. عشان هيك بنحكي لك مثلا تلعب رياضة أو تبني عضلات you play just to the point of exhaustion للmuscle and then you stop خلاص. More than that is muscle damage and then you stop for 2 days حتى بتستنى يوم هذا واليوم اللي وراه ما تلعب وبعدين اليوم الثالث تلعب. This will help the muscle recover and then grow because the only thing that you're doing is you're giving the signal for the muscle to grow. That's why you reach to مثلا the anaerobic conditions of the muscle and that's it. That's all you need to do. If you do too much strain or you get a trauma, this will destroy the muscle. This becomes again نفس القصة حكينا عنها فيما سبق إنه that patient will have destruction in that area which may make it ideal. زي حكينا قصة الشارع صار خربان, so any bacteria that is traveling will more likely not be able to continue and stop there and find lots of dead cells وخلاص بتعيش حياتها هناك. So pyomyositis infection usually remains localized and then shock does not develop unless organisms produce. So شو هم toxic shock syndrome TSST1 and you know that one. So the super antigen that causes exaggerated immune response بصير عندك shock and enterotoxins. This is like exotoxin produced by Staph aureus. Now if the patient lacks antibodies to these toxins, have not met them before, so they are prone to having shock when these toxins are produced in that area. Pyomyositis, pus forming infection of skeletal muscle. Abscess formation is the usual consequence of these pyogenic bacteria and usually arises from hematogenous spread like we just said, and deeper infection in muscle and bone are typically more related to hematogenous spread rather than direct inoculation. هاي قصة القلعة اللي حكيناها. So epidemiology occurs males more than females and more in tropical climate in two main age groups. كتير هاي مهمة tropical climate بحبوها اليوسمري. Children aged 2 to 5 years and then adults 20 to 4 to 50 يعني اضربه ب10. So in temperate climates pyomyositis typically affects adults or the elderly, not children. Patients usually have predisposing conditions such as HIV infection, DM, malignancy, cirrhosis, renal insufficiency, organ transplantation, reduced cell immunity. ليش organ transplantation عندهم reduced cell immunity? This is iatrogenic. We make it because we don't want their cell immunity to attack their organ. Immunosuppressive therapy. Other risk factors include trauma, IgU, and concurrent infections. مثلا. Microbiology. Staph aureus, 90% of tropical cases and 75% of temperate cases. Group A strep accounts for about 1 to 5% of cases all around. E. coli, strain type 131, is an emerging cause in patients with hematological malignancy. This is important. Uncommon causes. هاي راح تشوفوا أكثر وأكثر مع practice. By the time you practice, it'll probably be more of an issue. Uncommon causes: BCG, streptococci, pneumococcus, strep anginosus. كل هدول قاعدين uncommon. والرير الأشياء الثانية. Clinical features. شو راح يكون؟ They have had usually about 20 to 50% of patients had recent blunt trauma or vigorous exercise of the affected area. So there is a predisposing myolysis. And then the muscle area is damaged and becomes susceptible for infection. So these patients, زي ما حكينا, they have traveling bacteria and then they have caused damage in the muscle, which قصة الشارع انكسر ونزل كله والحكي نفسه كله. So seen more in lower extremity, thigh, calf, gluteal muscles, but not limited to that area and can affect any muscle group. ليش lower extremity? Again, this can be a bit controversial, but people are more likely to يلعبوا مثلا حركات كارديو مثلا أكثر من البادي building. So more likely to have trauma or severe exercise مثلا in the legs. هاي نقطة. والنقطة الثانية more likely to have trauma blunt trauma in the leg rather than the arm, بس لأنه leg is just the larger limb يعني. So multifocal infections occurs in up to 20% of cases. So this is يعني supports all what we have been saying. Since it is usually from hematological causes, the patient must be assessed for complications of bacteremia. بتخاف إنه عنده أشياء تانية البكتيريا. Why is there bacteria in the blood? Has the bacteria seeded elsewhere? So this is something you want to worry about. هون ولا بالosteomyelitis or anything else. Clinical stages. Stage 1, you have an early invasive stage. So crampy local muscle pain, swelling, low-grade fever, induration, hardening of the affected muscle, leukocytosis may be present. Stage 2, here the suppurative stage starts about 10 days to about the 3-week mark, and then من بداية symptoms, very sharp muscle tenderness, swelling, abscess may be clinically apparent, aspiration yields pus, there is marked leukocytosis بالblood. Stage 3, the systemic stage. Here patients may see عندهم complications, bacteremia, septic shock, endocarditis, septic emboli, pneumonia, pericarditis, septic arthritis, brain abscess, acute renal failure, rhabdomyolysis. A lot of things can happen with the destruction and then of the muscle and the continued infection. Diagnosis. Early pyomyositis is difficult to distinguish. هاي القصة اللي حكيناها إنه deeper tissues don't have that symptoms until late, but that's why it's difficult. So مثلا other diagnosis مثلا هل عنده thrombophlebitis, muscle hematoma, muscle rupture, fever, unknown origin, osteomyelitis, أشياء كتيرة. Iliacus pyomyositis may mimic septic arthritis of the hip, and ileopsoas pyomyositis may mimic appendicitis. The appendix, when it bursts, it will affect عادة السوس muscle. السوس muscle تكون تحتيها. Iliacus pyomyositis هون ببين زي كأنه septic arthritis of the hip. MRI is the gold standard technique in this case. May show muscle enhancement and then intramuscular abscess as well. CT may detect muscle swelling and well-defined abscesses, and then ultrasound can be helpful for diagnosis and treatment to guide aspiration. Microbiology, diagnostic aspirates before starting antibiotics to get a specific culture. Blood cultures are only positive in 10% of tropical cases and 35% of temperate cases. So here the tissue is إنه صار في seeding خلاص seeding صار وخلص. So you will not unlikely to see the bacteria in the blood. So where will you see the bacteria? In the aspirate from the muscle itself. So pyomyositis would not usually be the initial diagnosis. أول ما طلع شيء راح تفكر بالأشياء الثانية كلها قبل ما تفكر بالpyomyositis. So you want to worry about مثلا طلع شكله هل هو cellulitis, هل هو مثلا necrotizing fasciitis, هل هو before you see. So what you want to do is imaging here. That's why imaging will help you عشان تعرف لما نعمل imaging مش إنه إحنا نعرف when the involvement is where is the primary involvement. So here pyomyositis in the thigh in a young patient with severe aplastic anemia. So هون كانت E. coli, the agent was E. coli, and then هذا حكينا قبل شوية. So you can see the muscle enhancement inside the muscle itself. Management, antibiotics. Stage 1 antibiotics alone. However, most patients present at the second or third stage of the disease and require antibiotics plus drainage. So empiric therapy for these stages directed against Staph aureus and streptococci, anti-staph with vancomycin. If you suspect MRSA. Immunocompromised patients, broader antibiotics, piperacillin, tazobactam, plus or minus vancomycin. لما تعرف الculture, but you tailor it for about 3 to 4 weeks. Drainage, percutaneous drainage, like the story with septic arthritis, is maybe CT guided, ultrasound guided. هاي هنا septic arthritis that we just finished. يعطيكم العافية. We will schedule إن شاء الله تعالى when we would like to do the Q&A session. I would prefer to do one near the end of the course عشان نجمع المعلومات كلها مع بعضها, and then we try to tie in with other subjects مثلا, and then we take it from there. ويعطيكم العافية.